Good evening, everyone. Here, Dr. Imran Abbas from Dubai. We are live on GLR TV. It is a great honor for me. We have live Professor Robert Rutledge and Professor Kolar. And really, it is great honor. And thanks, Professor Rutledge, as well as Professor Kolar. So this is a great opportunity for all of us as well as you all viewers. So now this is just interview with the legends of surgery. So it will again a great honor. We have started this initiative with Professor Robert Rutledge. So I will not take more time. So this is the time for Professor Robert Rutledge and Professor Kolar. If you have any question, so you can ask any question and we are here. So just this is an interview in light mood. You can ask any question. I will ask some questions. And if you want to add any type of question regarding MGB, Mini Gastric Bypass, so just now we are here, Professor is here and ready for Professor Robert Rutledge. Sir, highly welcome. First of all, thanks for you and from GLR team and GLR TV. And we want to hear a brief introduction from yourself as well as Professor Kolar. Sir, over to you.
Great, it's good to be here, and I want to thank you and congratulate you on the hard work you're doing, using this time of pandemic in an innovative way to educate interested surgeons. The travel where we would go to meetings in the past has been curtailed, but you have spearheaded this new approach. And so it is a pleasure and an honor to be here with you and Dr. Kolar.
Sir Kolar, over to you. Sir, your brief introduction, your center, your academic and clinical activities. So because we have a lot of youngsters that are attached with our organization, this global laparoscopy and robotics, they need training. So we want to hear from your side.
Thank you, Professor Abbas. Thank you, Dr. Rutledge. I think my introduction goes with Professor Rutledge because whatever I am doing is all because of him. It was like more than a decade back when I, visited his center and saw him doing the mini gastric bypass in 19 minutes. And then saw the results and saw how the patients were eating. Actually, before that, I got trained in Texas, and we were doing Roux-en-Y gastric bypass with a small pouch. The main problem which we were facing here in Punjab was that our patients, the Punjabis, they want to eat.
Yeah.
And eating is something which is like, we don't just eat to fill our tummies. So basically we eat to satisfy our brain.
Yeah.
So, and that is what I saw in the mini gastric bypass. It gives you satisfaction. And I met his patients, his post-op patients, immediate post-ops, and then 10-year post-ops, and then 15-year post-ops. And I was so satisfied. And I took no time to understand that this is the procedure which will, work in Punjab. And then, we started this center, Kolar Hospital. It is on the outskirts of Ludhiana on the National Highway. When you go from New Delhi to Ludhiana, Punjab, this hospital is on the National Highway. We have a nursing school also. The building is there in about 3 acres. It's a multi-specialty hospital. But my duty is just to do bariatric surgery, and we have been doing mini gastric bypasses from last more than 15 years. And I'm lucky enough to be associated with Professor Rutledge for about 15 years. And he has been visiting my center more than twice a year. And we are lucky to be here in this pandemic from last about 10 months. We have been working together. Thank you, Professor Abbas.
Thank you, sir. Thank you, really. It is a great information about your center also as well. And someone, because who are interested for training programs, so Professor Kolar is there and they have a big institute, and then we will stay in touch with each other. Sir, Professor Rutledge, I have one question that is a common question from most of our youngsters and also bariatric surgeons, when and why have you started mini gastric bypass?
Oh, that's a great question. And I have some slides on that, and I'll tell you my story because I know you think I look very young. Well, but I'm actually an old trauma surgeon. Quiet, Kular. So I'm going to share my screen for a second, and then we'll show some slides, and I'll give you the answer to that history. It also is important because there's no such thing as the mini gastric bypass, as I'll point out. The mini gastric bypass is nothing more than general surgery. It's an antrectomy in Billroth 2, 140-year-old operation. Those people who are critical of it are often just confused. And so we'll touch on those two topics, and give me 1 second, I'll share my screen.
Sure, sir.
It says the host has disabled participant screen sharing.
Yeah.
Okay.
Now you can share, sir.
Okay, 1 second. Good. Okay, I'm going to do an introduction a little bit, and then I will go to give a history. So 1 second now, and share screen, and here, share. So can you see the slide?
Yeah, sir, we can see.
So the introduction is first to ask about the history is wise, but I also wanted to say why I thought your idea of talking about the MGB was valuable and important. And what I want to point out is that recently and in the past, there have been reports of death and complications after the MGB, and I wanted to argue that it's not exactly an MGB that's being done, and it's not being done maybe by very educated or knowledgeable surgeons. And as an example, MGB bile reflux, and this is a recent study, in fact, 2 studies that said expected procedure complications, are these what we must plan on? Or is it true that surgical technique and post-op diet and lifestyle might be the cause? That is, maybe the surgeons who are having 35% bile reflux are actually doing a procedure that's a little bit different than the 0.3% bile reflux from a recent study in England. And so my argument is, like, for example, the Y-omega trial. They said OAGB had 20% of patients had diarrhea. Yet I don't think Dr. Kular and I seem to see 20% of our patients with diarrhea. They said that the OAGB patients had 11 grams of fat as measured in standard stool samples. 20% had gastritis and 10% esophagitis. And I don't think Dr. Kular and I or my other friends doing MGB around the world that I speak with have these kind of outcomes. But we have good honorable surgeons publishing quite bad outcomes with a Billroth 2 type operation. And we kind of say a good MGB, that is one done with skill and insight, and I hope I can pass on some tricks about that today, doesn't have a 20% gastritis or a 10% esophagitis, and doesn't have 20% diarrhea. And so we have a kind of a paradox. There are good honorable surgeons who are seeing very bad outcomes and publishing bad outcomes. And we have a very famous surgeon here in India who published a series of studies where he did MGBs, and I volunteered to go and maybe work with him, but he's very knowledgeable, didn't take up on that, and he's had very bad outcomes from his patients. What we think is we don't want to convince anybody to do the MGB. If you think the MGB is bad, don't do it. It's taking off around the world, but if you are interested, and maybe I can help tonight, learn to do it well. Don't be a Y-omega. That's what we like to say. Malabsorption. Now, one of the things we talk about is malabsorption, and because you've asked me to do the history, I'm going to skip over this. But malabsorption is a funny question because we don't see it in most of the surgeons who are high volume. And I'll go over that if there are more questions about that. And we'll talk about bile about bowel length maybe, and we have some slides that we'll talk about that. And I'll skip down to the little bit of history. There's some technical points where we put the staple gun and how we do it and the complications that we could talk about if you wish. But I would like to take a moment again and thank Dr. Kular and my friend Dr. Magenda here and the opportunity to speak with you all tonight. This is where I have been around the world teaching MGB, you know, from Cairo and India. Australia is not on there, but Australia also. And here are some of the places. This is my course, a 2-day course on the MGB Bronze Certificate course. And I think Dr. Imran Abbas and I are going to talk about that. But this is me in Australia and Pakistan and Portugal and Turkey and Birmingham, England and Spain, Portugal, Kazakhstan, Italy, and other places around the world. And so again, we're kind of going to talk about 2 topics. These reported complications and some new plans and new research. But of course, I'll interrupt and have questions anytime. But we're going to go quickly then to the history. Okay, so I'm a trauma surgeon for 20 years. I took care of trauma patients, and in 1997, I was one of the early adopters of laparoscopic Roux-en-Y gastric bypass. And then I can tell you in 1997, it was very challenging. We did Roux-en-Y, and we had to push a EEA stapler through the abdominal wall. And my friends said, that's a bad idea, don't do this. But I kept going. But it was very difficult. Well, on a Thursday night in September 1997, a drug dealer in my town had a disagreement about the pricing, and his customer shot him in the belly 6 times with a large caliber handgun called a .357 Magnum. I rushed him to the operating room about 9 o'clock that night, and we had multiple bullet wounds to the stomach, the pancreas, and multiple loops of small bowel and the kidney. To treat him that night, I did a distal gastrectomy, a distal pancreatectomy and splenectomy, and repaired multiple loops of small bowel. Okay? And what I did is I reconstructed the stomach, and those of you who know the MGB will already see what I did, which was, that's almost an MGB. It was done for trauma, and it's been done for 140 years. This operation is well studied. We know about it. And when people say they don't understand or they're suspicious of the MGB, it's a little bit foolish because we've had this for 100 years. And I did it in 97. And the next morning, I had a laparoscopic Roux-en-Y. And I said to myself, I'll just make a callus gastroplasty here and do a loop. And then in those days, it was called minimally invasive surgery. And instead, of course, the medical term for this is a callus gastroplasty with an anticolic Billroth 2 gastrojejunostomy. And my patients didn't quite understand that. So I invented a minimally invasive gastric bypass, or a mini gastric bypass. And of course, here's the mini gastric bypass. And it does not violate general surgery like the old loop bypass. The old Mason bypass had the bypass up here. And of course, we all know that when you make a short pouch like this, that's when you have to convert to Roux-en-Y. But research around the world shows that this is really a good operation. This operation, for example, in the country of Taiwan, they studied 6,000 Billroth 2 patients compared to ulcer patients who had no surgery. And this operation, nothing more than an ulcer operation, cut diabetes in half, cut heart attack, stroke, and death by just having an ulcer operation. And of course, this one modifies that by a little bit longer bypass and a little bit less gastric remnant. So 20 years later, the MGB is not a Roux-en-Y with one less anastomosis, and that's kind of the background, and maybe I'll pause there for a second and see if you have other questions. Or I could keep going. Do you want me to continue, or do you want to ask another question? Sir, that's the history.
Sir, I will ask some questions. So because this is just like an interview, so another question. Yes, sir, we understand this. So this was like this incidental because you are a trauma surgeon and there is also previous history like MGB, like Mason procedure. We had also Bill Roth too. So this is all these things. So this is a evolution like this process of MGB or mini gastric bypass. So sir, why you select this name, mini gastric bypass?
In 1997, you were probably quite younger then. In 1997, there was not laparoscopic surgery. Instead, it was called minimally invasive. So mini was minimally invasive, and it was a minimally invasive gastric bypass. So I shortened that because my patients couldn't quite get to minimally invasive gastric bypass, so just MGB is what happened.
I understand, sir. Thank you, sir. And sir, another thing. So because when you have started this technique, so you have faced some side effects or complications like reflux, like marginal ulcer. So progressively, have you changed your technique, like length of pouch and also this width of pouch due to any malnutrition? So also this gastrocnestomy. So this how much the size of this this anastomosis. So like 3 centimeter, 5, 6, and why have you changed progressively your technique of MGB during this 23 years?
I would say what I see, and I think Dr. Kular maybe could comment, but what I see is, in fact, sorry, one second. What I see, sir, is that the operation that I have been doing for 23 years hasn't changed much. What I see is people say, mini gastric bypass, it's just a sleeve and a Roux-en-Y with a less anastomosis. And so then they do it their way. And I can give you some examples. They don't really listen to me because they feel like they're very expert. They're an expert sleeve surgeon, expert Roux-en-Y surgeon. And so they go forward and do things that I wouldn't recommend. And so one of the things that would be, I think, valuable tonight is to point out just some of these things, because there are many areas where the MGB, for example, pouch, which resembles a sleeve in some ways, is absolutely not a sleeve. And there is the bowel bypass, and there is, I think, deep confusion about that. And I could just give you a quick comment. Many people say, oh my goodness, you're going to have malnutrition with the MGB. Well, let's just think about that just for a moment. Let's imagine that the average length of the small bowel is around 6 meters. Now, probably more close to 7, and there is some variation, but just keep in your mind for a second something really simple. The average length of the average person is around 6 meters, okay? Now we bypass in the MGB maybe 1.5 or 2 meters. That means that our common channel, if we say 2 meters, 2 from 6 is around 4 meters. Yet the SADI people and the BPD people, they're keeping a common channel. It used to be 100 centimeters, 1 meter, then 1.5, then 2.5, and now I think they're up to 3. Soon they will join us. If they go up to 4, they will reach us. But very few people are frightened or worried about malnutrition after SADI and BPD, but MGB seems to be on people's radar, and they're saying it's risky of excessive weight loss. And I believe that's a misunderstanding. But if you look at BP limb length, and this is worth talking about for a second, the MGB BP limb length between 150 and 200 or even 250 is much shorter bypass than the bypass for SADI or BPD.
Excellent. Sir Kular, can you hear me?
Yeah, Professor Vas, yeah, sure.
Thank you. Sir, regarding same question from your side. So you have started about 15 years. So can you highlight technical points? So you changed your technique like length of pouch, width of pouch, or gastrocnestomy and diameter, and why you have changed your technique? Like have you faced any reflux or marginal ulcers or any chronic pain epigastric region due to this I want to hear from your side because you have a lot of experience in MGB.
Right. Thank you, Professor Abbas. First of all, about the change in the technique, I must tell you that initially when I started the mini gastric bypass and talked to other friends, who were into the old practice of doing Roux-en-Y gastric bypass or the sleeve gastrectomy or the uh, gastric band.
Yeah.
Basically, yeah, the main, skepticism was that nobody was ready to buy this idea of mini gastric bypass with a wide outlet, because this was the main thing, which would tell me that why a wide outlet, because the main concept in bariatric surgery used to be tight tight outlet, small pouch, maybe band at the outlet. And we used to think that maybe the big outlet will allow the patient to eat a lot, and uh, and then how the weight is going to go down. So that was the main, apprehension when I started this mini gastric bypass. But when I looked at his patients, I sat with his patients and I ate with his patients, and I could see that they were eating a moderate amount of food, but not too much. They could not eat too much, but they were eating without vomiting, without nausea. So it looked like a magical kind of situation as compared to my old practice of doing Roux-en-Y and sleeve gastrectomy, where majority of my patients had a lot of retching, nausea, vomiting in the beginning, because because of the wide outlet. And now we understand, in these 15 years of practice, now we understand that mini gastric bypass is actually, it's a functional restriction. It doesn't give you a mechanical obstruction, unlike a gastric band or a sleeve gastrectomy. And patient is eating into the jejunum, into the loop. And patient cannot eat too much too fast, because it's like the old, feeding jejunostomy. From our practice of gastric surgery, we understand that if you have a patient of feeding jejunostomy and you try to, feed him milk with a lot of sugar, and if you try to do it fast, patient will not like it.
Yeah.
So I would say mini gastric bypass is like a wide bore feeding jejunostomy, where there is no obstruction from top to bottom. Esophagus, then the gastric tube is just approximately the same diameter as that of the esophagus. And then the gastric outlet of the new stomach is also the same as that of the esophageal diameter. And patient is eating right away into the loop. And our concept of marginal ulcers, which I was quite apprehensive in the beginning to start with, because we used to think that maybe the bile will cause ulcers in the stomach, or the marginal ulcers are coming from bile. But now there is a lot of evidence, and if you look at all the treatment options which are available for the marginal ulcers in any kind of gastrojejunostomy, may it be a Roux-en-Y gastrojejunostomy or a mini gastric bypass gastrojejunostomy or any other gastrojejunostomy in gastric surgery, what we are giving to our patients is the same treatment, the antacids, the PPIs. And in my practice of 15 years, we have been doing endoscopies on as many patients as possible, on almost the majority of the symptomatic patients for sure. But what we find is, if at all there is an ulcer, which in my series of about more than 7,000 patients, in my series, the incidence of ulcers is less than 1.5%. And what we see is either the patient is a smoker, or the patient is taking some kind of painkillers for the long run, which is causing the ulceration. What I believe, and maybe in the coming times, we all will agree to this, that it is not the bile which is causing the ulcers, because stomach, especially the distal part of the stomach, is quite used to the bile. In all the endoscopies which we are doing, Bile is physiologically present in the stomach. And that is how we see bile reflux in sleeve gastrectomy as well. So in mini gastric bypass, because of the wide outlet, as a matter of simple physics, Bernoulli's theorem tells us that if you have a wide outlet, the chances of back pressure, they go down. And this has been verified by Professor Tellini from Italy. He has checked the pressures inside the gastric tube and compared mini gastric bypass versus sleeve gastrectomy. And we understand that mini gastric bypass is actually a low pressure system. So what I want to convey here is that I tried to change the technique. I tried to make a tight outlet as tight as an outlet of a Roux-en-Y. I have tried everything, but let me be very honest and very clear that we are back to the square one. Because whatever Professor Rutledge has designed, a wide gastrojejunostomy, we are firing 45 mm, straight cartridge. And now, from last 8 years, I don't want to change this. I don't want to put any band over it. So the main understanding is patients should not be smoking, patients should not be taking the painkillers, the NSAIDs, and the vascularity of the gastrojejunostomy has to be very good. So the suturing should not be in multi-layers. If the vascularity is good, you don't see early ulcers, and the long-term ulcers are not because of bile. These are the same acid peptic ulcers and the same incidence which any gastrojejunostomy has had in the past, as we see the literature. Professor Rutledge. Thank you.
I love what you said there. And if Dr. Abbas will give me permission, I'd like to comment further, if I may.
Sir, I want to add one question regarding this, and then, sir, Professor Rutledge, over to you. So, sometime personally also I have faced my patients marginal ulcer at intestinal side.
Yes.
Not at stomach side, at intestinal side. Also cover this point. Please, sir, over to you.
So, I have some slides on this, and I'll describe it and see if you give me permission to show it.
Please, sir. Please, sir.
So here's what I would say. First of all, I have had my own experience, which is rarely to see ulcers. And it's okay for me to comment on that, but also I would say to your surgeons and to your patients, one option that's now available to us that wasn't available even 5 years ago or 10 years ago is you can come on my Facebook page, as you know, and there are thousands of my former patients and Dr. Kular's patients and others. Many of my patients now are 20 years out from their MGB. So you can talk directly to hundreds of my patients who are 10, 15, and 20 years since their MGB. And what you find is, at least my experience is, that the incidence of marginal ulcers is low. Yet, as you pointed out, there are surgeons who report, and I think they're honest, that they see high incidence of gastritis, high incidence of bile reflux, and high incidence of marginal ulcers. And so this is a paradox. Let me see if I can try to explain that and then comment on your experience as well, sir. What I'd like to say is, in my experience, talking to patients, and in my own cases, the marginal ulcer location is almost always on the lateral aspect of the anastomosis. When you go for a perforated ulcer, I have dozens of surgeons who have sent me their videos, and I can show several. The perforation is on the lateral or posterior lateral aspect. And I would remind you that location is very critical when a surgeon does the MGB. And I have a slide I'd like to show you while I describe the rest of this topic.
Sure, sir. No, continue. Okay.
Okay, I'm going to go 1 second to share a screen, so it'll take me 1 moment, sir.
So just Professor, you are sharing. So I must add, because one of our question from South Africa, the surgeon, Professor Ibrahim Mansour, he asked this question. He has 3 questions, but I think he received this question, how the size of GJ or gastrojejunostomy. So Dr. Mansoor, this size is 45 millimeter or 4.5 centimeter.
Right, so we'll talk about that. We'll talk about that, the size in a moment. Can you see this slide?
Yes, sir, we can see.
Okay, so imagine that this is the gastric pouch, yeah? And so this is the lesser curvature here.
Yes.
So this is the vascularity here. And this is the staple line. This is the lateral staple line. And I'm going to call that the neo-greater curvature, right?
Sure, sir.
And of course, the regular greater curvature, the normal, healthy greater curvature is highly vascular. But of course, this is completely devascularized and filled with 6 rows of titanium staples. And then the base here, depending on how the surgeon has made it, and we'll talk about other complications, and I have videos, but just imagine for this, let's see, visible, for this area, that now we're going to put a staple gun into the tip of the gastric pouch, and anterior, posterior, there's a lot more technical details, but just stay with me as far as ulcers and gastritis. If you put the staple gun here, then there is a reasonable chance that there might be collateral blood flow to this portion, this lateral portion of the pouch. Is that kind of understandable to you, sir?
Yes, sir. Excellent.
Now let's imagine, though, that the surgeon goes lateral. So they move the staple line of the gastrojejunostomy lateral. Now what you have is staple line with no vascularity, another staple line here, and ischemic and potentially dead tissue here. Now you have 12 titanium foreign body lines with dead tissue, and then being bathed in both bile and acid, as well as other enzymes. This becomes, when technically done in error, in my opinion, becomes a nidus for ulcers, gastritis, and other complications. So that my bias is, this is one small example of a technical error. This patient, if it's done by a surgeon, and I have actual live surgery to show surgeons doing this all the time, that they make this lateral staple line, then they put the gastrojejunostomy here, and so they have this ischemic zone, which is now a setup over the years to become ulcerated or gastritis and cause other symptomatology up to and including perforation. But it's a small technical detail, and when I talk to surgeons, they often don't understand that when I look at their video and say, here's why I think you might have gotten an ulcer. Here's why your patient may be vomiting bile. Because I'll mention one more thing. If you look at this, the lesser curvature is here, the greater curvature is here, and notice then that this should be straight line. What we see is if you take this on a variety of videos I can show you, because they push in the staple gun, they twist the whole pouch even 180 degrees or more. So now you have ischemia, and then you twist the pouch. That means it's going to empty poorly, that when bile does come back, it'll tend to retain. Plus you have ischemia. Those technical details, just a few of the examples of harming the patient because of not understanding simple technical details.
Sir, excellent. And just if I ask another question, when we make this pouch and gastrojejunostomy, sometimes we see there is a small twist at the site of. So are you agree in such a situation to fix this gastrojejunostomy with remnant that pylorus side? So if we do a stitch, no, okay, sir.
Can I comment on that? That's a very good question. Let me restate your question. Do I have your permission to restate your question, sir?
Sir, yes, please, sir.
Okay, so what Dr. Abbas asked is a brilliant question, and it goes back to another important point. So let's talk about bile reflux. And let's talk about surgeons who often say, when I do the MGB, I dissect the hiatus, I identify the crura, and I repair the hiatal hernia, yes?
Yes.
But we never do that. I don't think Kular does it, and I don't do that. And there is a reason, if I can explain. The MGB is an anti-reflux procedure. Let me do the steps. Number one, we have weight loss, which of course helps with reflux. Number two is that we change the pressure dynamics, as Dr. Kular has mentioned. What he said is when you take away the pylorus and have a wide open gastrojejunostomy, not twisted, not kinked, not obstructed, not irritated, not spastic, that means that the pressure in the EG junction will always outman the pressure at the gastrojejunostomy if it's done technically correctly. So you create, as Dr. Kular said, as Dr. Tuloni in Italy has shown, a low pressure system, so there's going to be a natural pressure gradient pushing fluid out of the gastric pouch. But then more important, often misunderstood and brought up, why don't we put a stitch here to keep this gastrojejunostomy untwisted? But we don't want a stitch there, because what we want is to remember the small bowel we have brought up, we have had to pull up from the lower abdomen. And when we stitch it here, what happens? It naturally wants to hang down. And what does it do? It reduces the hernia. And the problem of reflux is the herniation up into the low pressure chest and out of the high pressure abdomen, which helps close it. So I was talking to a surgeon yesterday. He says, I stitch both these things to anchor it. No, you need to not twist it in the first place. If you've made a twist, you don't stitch it. You don't want to stitch there. And you got a great question. What you want desperately is to hang that small bowel off of that gastrojejunostomy and pull down and reduce the hernia.
No, sir, I understand, but my question is regarding fixation of gastrojejunostomy, because we have twist at that side.
The twist should not be created, and you don't want to anchor it because you want to pull down. When you stitch it, you take off some of the tension off that gastric pouch. We want that natural tension of the stomach being pulled down into the abdomen. Remember, of course, it's a hiatal hernia. So what we do is we grab a hold of the gastric pouch and reduce it. And we do that by the small bowel has tension and pulls it down. Now, if it's twisted, we have to prevent that ahead of time. We don't want to create a twisted pouch, but we don't fix it by stitching it back to untwist it. What we do is create a good pouch in the first step.
I agree with you, sir. Excellent, sir, and really appreciable. Sir Kular, can you hear me?
Yes, Professor Bas, yeah.
Sir Kular, any contraindication of MGB in your experience? Which patient is not good candidate for MGB?
Yeah, actually, the main contraindication which we see sometimes on the table when the liver is not in a good condition, and we would not do a mini gastric bypass when you have a cirrhosis with ascites. But the point is then what you will do, because those patients might need a liver transplant later on, and those patients, they need weight loss. That is kind of indispensable for them. So the other options which we used to try like 6-7 years back were going in for sleeve gastrectomy in those cases, or other restrictive procedures. But even sleeve gastrectomy, if it is tight and if patient cannot eat, and if patient loses too much too fast, that is not good for the liver too. So we have been doing mini gastroplasty in such cases where mini gastric bypass is contraindicated. So what we will do, if the liver is not good, probably to my mind that is the only thing which makes me apprehensive, not to do this. So we will put the gastric tube, which we have constructed for the mini gastric bypass. We will put the gastric tube to the stomach in the area of the junction of the body to the antrum, so that it will be something like the old vertical gastroplasty, which is non-banded.
Yeah.
But the good thing is that it is reversible, unlike sleeve gastrectomy. in case, God forbid, we know there are case reports. There is enough evidence that even sleeve gastrectomy can sometimes push a patient into liver failure if the liver is not good. So what to do next? But here you have the choice of even undoing this gastroplasty, which we have named it mini gastroplasty with Dr. Rutledge, and we have seen very good success in these patients. And later on, after 1 year, we do their fiber scan and see when the patient has improved. And if further weight loss is required, then we can switch this procedure easily to mini gastric bypass. And or otherwise, even if I have a young patient, even less than 18 years, earlier I used to do a sleeve gastrectomy, but now, let me be very honest, we are doing mini gastric bypass in even young patients like 16 years old, 14 years old, whenever there is an indication for bariatric surgery. If at all bariatric surgery is required, we will be doing mini gastric bypass, even if the patient is 14 years old. Again, because of the same reason, we see so much strong evidence of the reflux disease after sleeve gastrectomy, especially the new onset GERD, which is very less with the mini gastric bypass. And in the long run, we don't want our young patients to be living with GERD. So again, that is something which makes a strong indication in favor of mini gastric bypass, even if the patient is young, and even if patient is old, too old, like 80 years old, but fit to handle a surgery of 20 minutes, again, mini gastric bypass is good. Because we will alter the length of the bypass. For fragile patients, we will give them a smaller length. And even if the patient is super obese, mini gastric bypass is a one-time procedure for them. So even in those cases, we would select this.
Circular.
When a patient is a smoker, I would not be doing a mini gastric bypass earlier, but now even in smokers, with a good warning and with the 2 months before the surgery, a kind of de-addiction, telling them to stop the smoking and then come back for mini gastric bypass. This is what we are promoting. Yes.
Sir, excellent. And because now this is a new debate, hopefully, and in next our session we will discuss about this reverse or gastroplasty, especially in such a case. Because now I will continue my same question. Professor Rutledge, can you hear me?
Yes, sir.
Sir, regarding this contraindication of MGB, if someone has a hiatal hernia and large size hiatal hernia, and just we can see stomach is inside. So thoracic region, what will you do? You will do same mini gastric bypass, or no? You will prefer to repair this hiatal hernia?
Yes, even with large paraesophageal hernias, I've had about 4 of those. And what we do at the time of surgery, if it's diagnosed at that point, we just do a regular MGB. Remember that, again, we talk about how the small bowel pulls the stomach down and reduces the hernia. And again, we have to avoid a twist. We have to avoid the bile reflux. We have to avoid the ischemic tip, all those things we talked about. And I do have a set of a cartoon of how to do the MGB. We could talk about some of these other details, but as far as the hiatal hernia, we never touch it. And I could give you a little story that, I've been blessed to be invited to go around at different places around the world to talk about MGB. And usually when I am there, I'm the only one talking about MGB, and I sit quietly until I'm asked to talk. And sometimes they'll be polite, because all they'll be talking about is sleeve, sleeve, sleeve. And if you're talking about sleeves at a meeting, then something will come up called stents, stents and sleeves. And they'll talk about stents and placing the stent and how long the stent should be and everything. And someone will get up and show you a dozen of his patients with stents, and they'll be polite. They'll say, "Oh, Dr. Rutledge is here. Dr. Rutledge, could you comment?" And I said, "No, I don't know anything about any stents. We've never used a stent, and leaks are very uncommon because we don't dissect in the EG junction." And so that's my suggestion. It provides a really beautiful technique so that you don't face the tragedy of a leak. I will say about 20 years ago, I didn't realize this, and I did dissect in the area, and I did have a high leak like that, and I don't ever want to have that again.
Sir, if we continue this debate regarding especially reflux, so what is your opinion regarding anti-reflux stitch? Are this side-to-side gastrojejunostomy and same when we do this side-to-side gastrojejunostomy or when we do end-to-side like this loop? Sometimes this is the just this is my question. So we can there are two questions now also regarding reflux, also regarding afferent loop syndrome. So when food will particles will go also to afferent loop. So sir, what is your opinion about this?
Well, I think they're two complex questions. So number one is, I think each of us need to look at our own results. And if you look at Dr. Carbajo's results, there are no one on earth that has better results. So I honor Dr. Carbajo, I honor the OAGB, which is the original OAGB. Now it's been spread to cover MGB as well. But Dr. Carbajo, his results, the quality of his follow-up is just superb, you know. And I think you did some training with him, right?
Yeah.
Yeah, so we have tremendous respect for him. Now we do disagree a little bit, but I think it's like brothers, we disagree. Our rate of MGB reflux symptoms are so low that I don't do that additional side to side. And let me say why. I'll give you a story. I was on Facebook discussing revision, and I said revision of MGB is easy. And another surgeon said, no, you don't understand. It can be very difficult. And I said, no, it's like 20 minutes. You put the ports in, you divide the gastroj, and then you do gastrogastrostomy. It takes, you know, you can have a haircut in more time than it takes to revise an MGB. And he said, no, I fought for an hour with a surgeon one time. And I said, sir, I apologize. And he said, he was revising an OAGB. So when you do that additional suturing, it means that revision becomes a bit more challenging. And revision of MGB is rare, but if you have somebody who's sick and you want to get out of an MGB, the MGB, the beauty of it to me, like let's suppose you choose a patient who might have a risk of alcohol. You choose someone who might have a risk of taking drugs, or they might have psychiatric problems or things like that. What I take and tell the patient is that, God forbid, the tragedy that the MGB is not the best choice for you. I say, bring it back, bring your wife, she can go to the hairdresser. Before she is back, your MGB will be undone. It's so easy to undo it. I have videos of that I can show you, but again, you should never hesitate to undo the surgery because it's so easy to undo it. So if a patient is sick, if they have excessive weight loss or anything, I have a video that I show all my patients. It says, if you lose too much, we'll fix it. And I think that that makes it advantageous to not do any additional work near that anastomosis and up along there. If I think I have problems, I would certainly consider changing it. But when I talk to the surgeons like Dr. Kular, who are using my technique, you know, I talked to Carl Reinwald the other day, I talked to Dr. Hargroder in the US just today. I was talking to him about another call. And so my bias is technically done well and not a version or a modified version of the MGB has relatively low incidence of bile reflux. Now, when you twist it, when you kink it, when you do some other things, my fear is that that may increase the risk. On the other hand, anybody who's following Dr. Carbajo's technique, I support 100%.
Sure, sir. Thank you, sir. Really appreciable. Sir Kular, can you hear me?
Yes, Professor Gus.
One of the concern of MGB or any malabsorptive surgery, any type, is micronutrient deficiency. So how we can prevent, how you prevent, because as I know, and I am one of the follower of Professor Rutledge as well as you. So because there is in post-op, you have not a lot of multivitamins, and so you prefer this natural foods and diet, and yes, you can handle your patients. So I want to know also about technical points of MGB, especially BP Also, something like this, if you want to add, so how you can prevent, yeah, how you prevent this micronutrient deficiency in MGB cases, technical point of view.
Yes, Professor Abbas, yeah. See, technically speaking, when you look at all the evidence which has been published till date, the results have been very good with all the big series which have been published. But honestly speaking, when I started my practice of mini gastric bypass, especially in this area of India, I was quite skeptical like you, because even if I'm telling my patients to take vitamins, that doesn't mean that they will take the vitamins. Even if I'm giving it in writing, that doesn't mean that they are taking the vitamins. And now, you know, probably because in Indian system here, we are getting patients not through the insurance companies, not through any agencies. We are getting patients by the word of mouth, patient to patient chain.
Yeah,
So if my patients have problems, then how we are going to get the next patient?
yeah,
That was, my main, apprehension in the beginning. So for that matter, we have a very strong follow-up. You will see in my publications, our follow-up at 10 years is about 80%, which is kind of unbelievable even if you look at the American data. But now we know that sitting in India, we have 8 persons who are doing our follow-up, making calls to 30 patients every day. And we have a record of this in our emails. Every day I get 30 emails. Sorry, every day I get an email with a record of 30 patients. And now we have the Google forms which the patients are filling. We have their reports, how the iron is going, how the vitamin B12 is going. You know, uh, the point here is that with mini gastric bypass, you don't have to do a very long bypass. The amount of length of the intestine which we are using is not more than what has been used in the Roux-en-Y for about 60 years. Because if you look at the common channel in Roux-en-Y and the classical, typical mini gastric bypass, it's almost the same. But the only difference is in mini gastric bypass, there is no Roux limb. The whole
Right.
of length of the bypass is attributed to make this bypass of the mini gastric bypass. I mean, the BP limb of the mini gastric bypass. But the common limb is the same. So I fail to understand why there is so much of misunderstanding and misconception, especially after the Y Omega trial, which came from France, about the micronutrient deficiencies, about the malnutrition. We need to understand that when we talk about bariatric surgery, it has to be a combination. We know gastric bypass was considered as a gold standard procedure. The problem with gastric bypass has not been the micronutrient deficiencies. The problems have been, other problems like difficulty in revising, difficulty in maintaining the lost weight. And here with mini gastric bypass, we are seeing so good results, and even the incidence of bile reflux is so less, incidence of the micronutrient deficiencies. Now it doesn't fear me. Honestly speaking, if this was the problem, I would have stopped doing the mini gastric bypass, maybe 10 years back. Because here in India, in especially this part of Punjab, now our Punjabis are sitting at New Delhi. You see every day on the television,
yeah.
they can come outside my hospital as well.
Sure, sir.
We people are so honest. If there is any trouble, I cannot continue my practice here. Don't you need to believe us. The thing is, we have to do the investigations. Sometimes, even if the patient is not ready to pay for it, even then I do it when the patient is coming in the follow-up, especially for a poor patient, because we need to maintain our data. So micronutrient deficiency with the 180 to 200 centimeters of bypass, now it doesn't fear me because in my data, It's almost negligible. And sometimes, when you have a malnutrition, I was discussing with Professor Rutledge the other day, we should not always blame the length, because the same length used in more than 7,000 patients has worked well. What if there are 10 patients who have gone into malnutrition with the same length? What is the reason? You have a long loop. There can be a blind loop. There can be, Clostridium difficile sitting there, causing the infection and pushing the patient into malnutrition. You need to look at these things as well. It's, very easy to say that it's the length, but technically speaking, when it is the same length, then why some patients should be pushed into malnutrition? So the overall technicality, how you are making the gastric tube, how you are making the anastomosis, how you are counting the limb. And when we do a very long bypass, then obviously we are counting the common channel. We look at the common channel, how much is left behind. And now we have our comparison of long bypasses versus intermediate and short length bypasses. As regards the short length, we are even doing up to 100 centimeters now in some patients who don't need to lose that much. So we are doing a tailored bypass, and we are very satisfied when I look at our data. And looking at the malnutrition thing, I think we are quite confident that the procedure works well, so long as the patient is eating and so long as you are doing a good follow-up. Yes.
Sir, excellent. Thank you, Professor Kular. Sir, Robert Rutledge. So regarding a redo case, if someone after weight regain and also sleeve gastrectomy and weight regain, you prefer same length BP limb or no? This will be changed.
In my experience, I can tell you this is what happened for me over the 20 years. So when I did my first MGB, I bypassed only 3 feet, so 1 meter. And weight loss was okay, but not so great. And then I went to 2 meters, and that's what I did for about 1,000 or so patients. And what I found is when I did my first few hundred failed lap bands, that if you do a 150 to 200 centimeter bypass, that their weight loss was significantly less than a primary case. And of course, the literature is very clear that second operations for bariatric surgery is much less effective. So what I suggest is that, first of all, I think surgeons and patients need to have a healthy fear of the second operation, because many people who do sleeves tell me, well, when they fail their sleeve, I'll just do something else. And I would tell you, I was doing a similar online discussion with some surgeons, one from Qatar or Qatar, and another from Somalia. And the young lady from Qatar said that her #1 case in her hospital is failed sleeves, so that the failed sleeves are now outnumbering the sleeves. So I think that your question is very important. And my experience is that you have to add almost another meter to the bypass. And so you might say, oh my goodness, to bypass that much. No, that's not that much when you compare it to a SADI. It's not that much when you compare it to those other complicated surgeries. So my opinion is a failed sleeve is going to be a difficult case, not because the surgery is difficult, because that decision to make a longer bypass has some criticisms, but I think that's the thing that I choose.
Thank you, sir. Sir, we have really lot of questions regarding this. There is no doubt, because we all, because now in Middle East, you know better than me, MGB or mini gastric bypass is the main practice. So just now I will, because due to shortage of time, I prefer to take some questions from our audience. So Professor Laurent Layani and Patrick Noel, their comment is regarding repairing a fatal hernia, and hopefully Professor Laurent, so you will be also, we will invite you, and also we will discuss about, because I will continue this MGB and OAGB series. So hopefully we will have this opportunity to hear more from Laurent Layani as well as Patrick. Professor Amir Khan from UK, he has a question regarding technical landmarks for forming pouch. So this gastric pouch, sir, if you explain about this, the question from Professor Amir Khan.
Yeah. Yes, I have some pictures of the pouch. I think his question is very wise, and I hope I will send my greetings to him. He's a surgeon who I know and I have a great honor for. And but I have some drawings, and then I have some errors that I would get your permission to show. It will take a few moments. Is that okay?
Okay, sir, please.
Okay, 1 second. I'll share my screen.
Sure, sir.
First, I'm going to show some errors. So 1 second. Share screen.
Because this is the main issue, sir, because these technical points are more important in my opinion. As you have
I think so. I think it's very important, and I appreciate you giving me the opportunity. We looked at this a minute ago, but now we're going to go on to some further. I'm going to talk about the twisted pouch. I see this all the time. It's common in Roux-en-Y surgeons. They have low port sites. They sit between the legs, and they have a poor first staple firing. It begins to twist. And the second common error is a short posterior wall, like I was talking about, and these lead to twists, and I'll show you some of these. And so they think sometimes it's a good idea. So it looks good. They do what's called an anterior surface of the stomach pouch to the bowel, which makes almost like a tourniquet effect. And that patient will have, in my experience, marginal ulcer, anorexia, vomiting, and bile reflux. So this is what I would say is an almost perfect pouch. And so if we're going to look here, here is the lesser curvature. Here is the lesser curvature in the position, which is straight across where this yellow line is. So if absolutely medial, this is the lesser curvature. Here's the staple line. And then what we see is the opposite of what we fear, which is what we call the bird's beak defect. Many of the Roux-en-Y surgeons, the sleeve surgeons, sit between the legs. The staple gun comes in from below, and instead of having this wide tip, you see how wide that is? Instead of having that, they go up like this. The staple gun is up like this. So then this becomes a bird's beak defect, so they shorten the pouch. Now you don't need to go into the antrum, just at the crow's foot here. And then also look at the lateral staple line here. This is the neo-greater curvature, and that you notice how they sit. And we're going to look at errors as we go through this. Look at this pouch. I'll say that 3 more times. Look at this pouch. Look at this pouch. This is that tip.
twist. Yes.
You see it?
Yes. Agree.
You see it? What do you think this is going to do? That stomach has been twisted almost 180 degrees. Yeah. How do you think swallowing? How do you think repair of the hiatus? How do you think that bowel is going to work there? And you see this, when this anterior surface has been turned into a posterior surface, the gastrojejunostomy suddenly seems like a good idea on the anterior surface. I was teaching a course in Turkey, and there were 2 very experienced surgeons, and I was doing this gastrojejunostomy on the posterior wall, and they started barking at me through the microphone as I was operating, and they said, no, anterior. And I came up and I showed these videos and talked with them, and they say, maybe you are right. But here's what I say. Think of a clock. Think of, here is 9 o'clock, here is 3 o'clock. And what this has done is rotated around here. This is wrong. I see this all the time. I have a dozen videos. I can show this to you. And this happens because the staple gun comes in and the friction pushes this over. We'll look at this some more. Look at this. This one is a patient they called me about. It's a good friend, you know this surgeon, And this patient was called in trouble, and I said, just re-explore. I said, I think this is what you're going to find. And what happened was this was twisted, then afterwards it flopped back over. You see what happened? They did the anterior gastrojejunectomy, and what happened is that twist bounced back. You see?
Yeah.
Okay. Again, how do you think this patient is going to swallow? How long do you think the bile will sit in the stomach once it goes up in here? And the bile retention over time is what causes bile gastritis.
That's right.
There's a good research from back in World War II, and they did scintigraphy. The people who have bile go up in their stomach after a Billroth 2 is very common. The people who have bile gastritis on endoscopy are the ones where the bile goes into the stomach pouch and stays there. This is a relative obstruction. Nausea, vomiting, you can see it all right here. We'll show you more. All right. Now, what we see here is, look at, here's the tip. It's twisted. And look at this. Look at this. Okay. This is what we want. The staple gun should come in directly perpendicular to the lesser curvature. When you sit below in the legs, there's some desire not to put an extra port in, as if a 12mm port would make any difference. The first staple line should be perpendicular, in my opinion. Now this one, you see coming up, it's on the wrong side. What we want for this staple line is it should be going this way. We want to grab the greater curvature here, pull it lateral, spread it out, and make this pouch, this is right, but then this is between the legs. We want to go out this way. Okay, now what's happened? You see it? You see the tip? It's rotating around.
Yes.
Because that last one, friction, and now we've got the wrong angle. And look at this. You see? It's almost 90 degrees. There it is again, wrong angle. And again, this is the wrong angle for the staple gun. Correct angle is here. This is not too bad. But now what he's going to do, he's just going to sew this up in a ball. So I'm not going to talk about this too much, but essentially we often see you excellent surgeons, and I respect you. You see these excellent surgeons, they want to sew, and when they're done sewing, you see this beautiful outside line, and all this dead tissue has been buried inside. Let me say that again. When you have this beautiful inverted suture line, all this dead tissue, all that ischemic tissue has been put in the lumen. Again, they're creating an obstruction. If they everted that suture line, that dead tissue would be outside and you'd have a bigger lumen, but it doesn't look pretty. When I first came to India, now I think 15 years ago, Dr. Kular had about a dozen local surgeons, and they liked most of my surgery, but I had an everted suture line here, and they bitterly criticized me. Look at this. That's just terrible. Now I have if I have your permission, I have another series of errors that I'll show you for little technical tricks.
Sir, please.
Okay, 1 second. All right, I'm getting ready to share the screen. And here we go. Okay, mini technical errors, tips, and pointers. So these mistakes, I would say, harm and kill people. So here's another example. So we see the staple gun coming in from below. And so what happens is, here's kind of the crow's foot. This is where we want the staple line to be. And so the staple line is up here. It's coming across this way, which we don't want. And not only that, it's going angled up. And so we'll look at that in a second. So we're going to look at common mistakes. And what this does, of course, by shortening the pouch, you move the pouch and make it short. So you're basically creating an old Mason loop, and now you've got bile reflux in the esophagus. And now the blame goes to the MGB, when in my humble opinion, it should be the surgeon, because I'm willing to teach people to do the operation correctly, but a lot of people think, oh, it's just a sleeve with a Billroth tube. Here's another, see, look at the staple gun coming here. See, it's below, instead of coming from above. This is where we want it to be. Here's where it is. So we've lost all of this gastric pouch just being cut off. And now you'll see in a moment, he's going to have the staple gun come in from below, so that we'll lose the tip because of a bird's beak defect. Okay, so we can't really see this well, but the staple gun is going up here. It should be down here. Now, here's another common error. Let me see if I can explain this to you. This is a posterior gastrojejunostomy, correct?
Yeah.
And here is the lesser curvature medially, so that's good, right? And then the lateral meo-greater curvature is lateral, as it should be, correct? But now what they've done is, one second. What they've done is, this is the gastrojejunostomy here. Now just think about this. There's a staple line back here we can't see, and then he's closed it with a suture, and he's a very good surgeon, very skilled, but that means there's a suture line here, so all of this tissue is not getting any blood supply from this side. Yet he has another staple line here, there's no blood supply here. So this tissue here is all dead ischemic tissue. Okay? Creating a bunch of dead tissue at the gastrojejunostomy will lead to scarring. There's also titanium staples here. This is a setup also for stricture. Again, it's not twisted. It's not twisted, but what he's done is staple line here, cut here. There's no way for blood to get here. And I see this very commonly. They do the anterior suture, the anterior staple line and gastrojejunostomy. That's wrong. Here we have no twist. But look at this, they're creating dead tissue here. Okay, this patient, this surgeon was splitting the omentum, and we could talk about that, but you never, in my series, I don't think Couillard very often or has ever had to split the omentum. We want to go in that left gutter. So now let's look at some more twisted pouch pictures. This is an everted staple line. And all of this tissue, I just want to show you, gets buried and looks very beautiful when you do your beautiful suturing. And I know you're a very skilled surgeon, and probably those people are listening. But when you make it look beautiful from the outside, all this dead tissue is in the inside of the anastomosis. And if you put that wad of tissue, that's not much smaller than the whole gastrojejunostomy. But you look at it and you say, oh, it's beautiful. It's not beautiful to me.
Agree, sir. Absolutely agree.
Here it is, that's the everted staple line, and you can see on the left-hand side, all that dead tissue is thrown away. And you can do it with sutures as well. Don't bury that. We were taught to bury it. We now know that you can do an everted staple line. This dead tissue inside of that anastomosis is not what we want over the long term, in my opinion. Look at, that's beautiful, in my opinion. And the lumen, there's good research on loss of lumen when you do an inverted staple line, a suture line. So here is that, this is the bird's beak defect. So look, they're at the crow's foot roughly, but the staple gun, instead of coming here, like this angle, the staple gun comes here, almost 90 degrees different. So now he's going up here, and so now the pouch is being made out of this. That's not right. This is so-called bird's beak defect, yes?
Yeah.
And now look at this. This is going to be the pouch. No, 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 no. We want to go across here, over to the greater curvature and back. We want to create a cobra head. And if I have your permission later, I'll show you just some drawings of that. Look at that. You see, they threw away 3, 4, 5 centimeters, and even now it's going to be tight and narrow and obstructive. A tight, narrow sleeve, yes, not for MGB. Okay, here we're going to see that, the twisted gastric pouch. I have a couple more really twisted pouches. It's very common, very, very common. So many surgeons sit between the legs, the staple gun is below, they have a liver retractor in place, and the staple gun causes this friction and twists the pouch. There's the tip. This is what we want. I showed you this picture before. There's that twist again, same one. I'll skip through this. I apologize for repeating it. Okay, I think I'm done with that then. Do you want to go through, may I have your permission to, if I have another question, or I could show you the,
yeah, excellent, sir. So because due to shortage of time, so we will also prefer to our viewers. So there are a lot of questions because, you know, MGB and mini gastric bypass, in my opinion, if we take you 10 times, so again, it is much less because this is going to popular and popular, this surgery. And due to this, there are a lot of questions. So we have another question from Circular. Can you hear me?
Yes, Professor Abbas.
Yeah, from South Africa. So regarding what is your, he has many questions, but one of the question that I must highlight, what is your post-op feeding protocol? Sir, you both, this question from both of you.
You know what? For like 5 or 6 years, Professor Rutledge did not tell me the answer to this. But when we did surgery on one of his family members, I was lucky enough that he gave me this right to perform the surgery. And when we were sitting on the dining table the next day, she had chicken, she had salad, she had fruits. I said, why are you eating this? We were, in the beginning, we were telling our patients to be on liquid diet at least for 7 days, but she was eating. So the crux of the story is, you know, with a wide gastrogenostomy, as wide as the esophagus, there's no reason why the food will not go down if you're eating. And the fear of a leak should not be there because there is no mechanical obstruction. You have done the suturing, you have done the stapling. Only thing is there is some edema, some swelling for the first couple of days. We tell the patient to go slow, but patients are allowed to eat, have small bites, chew well right from day one. But for the beginners, it will be better. You know, sometimes if you have a twist like Dr. Rutledge showed the pictures, in that case, you know, sometimes there can be trouble. Otherwise, MGB patients should be eating comfortably, but we recommend going slow. In the first week, maybe semi-solids, and after that, switch to solids. But again, these patients won't be eating too much, too big, not big volume, because they are eating into the small bowel, into the jejunum. So they will chew well, go small, like a narrow tube. There is no obstruction. Patient is eating. So after 7 days, almost normal eating, but it will again take the patient about 4 to 6 weeks to come back to a pretty much normal diet. But nothing like drinking with a straw or drinking sip or something like that. Patient can hold full glass of milk or juice or soup, or they have a normal dalia or khichdi or dal or sabzi on day 2 with one bowl they can eat easily. So that's how we go.
Sir, excellent. Sir, Professor Rutledge, you want to add anything?
I would like to add a lot, but I think because of time, I will just leave it with Dr. Kular. I think this is a really good question. I have some very radical ideas. I think you can eat right away. I think that eating healthy foods and not, the common thing I hear when I talk to patients around the world now, Australia, Tehran, Israel, the Middle East, Europe, is I hear over and over again that bariatric surgeons are recommending protein powders and high protein. Let me say that this is an area of confusion. Again, I recommend that anybody who's interested come and talk to hundreds of MGB patients of mine that are 10, 15, or 20 years out. Ask if you can find one who has low protein. Huh? In other words, come to my site. There are 5,000 people on one of our groups. And I put out this message just the other day because I was talking to an Australian patient who'd had an MGB, and he's sick because his doctor says drink high protein powder drinks. And I said, no, that makes you sick. He says, yeah. He says, my doctor says I must have it. I said, go on my site. I said, you know, there are thousands of people there. Find one person who has low protein.
Excellent, sir, and really appreciable. So now, because this is a closing time, and just a message for youngsters who are new for MGB, sir, a message for them. For youngsters, new sir.
We think the MGB seems simple. It's deadly and can lead to complications if you misunderstand some things. You can harm the patient. Don't do an MGB because you've seen it. The Y omega surgeons, I am told by a surgeon who worked with them, did no extra effort other than reading my paper from 10 or 15 years ago. And I had one paragraph about how to do the MGB. And their results are bad. It led the entire country of France to stop doing MGB for a while. So my bias is that there are very good surgeons who are willing to teach. We want to teach. You are doing such a good job with your work here for many things, but please don't assume the MGB is trivially simple to do. It is simple to do once you know how to do it. Imagine you're going to do an inguinal hernia repair back when you were a very junior surgeon, okay? If you didn't have guidance and knowledge and read and study before you did that, that can be a difficult, dangerous, and you can harm the patient. The MGB is no different. It's general surgery. With some knowledge and some desire to learn it, you can do great things in helping the patient. But when you say it's nothing more than a sleeve or nothing more than a Roux Y with one connection, you can see just the few examples I had time to show you tonight. There are deadly consequences from doing any operation in surgery without knowledge, education, and attempting to be skilled at it before you operate on a patient.
Thank you, sir. Sir Kular, any message for youngsters?
Thank you, Professor Abbas. Thank you, Professor Rutledge. I would say mini gastric bypass from Professor Rutledge is more or less like a blessing, not only for our patients, but for our surgeons also, because it has given us a very strong, effective tool, which is easily reversible, revisable, and it's easily reproducible. But the only thing is we need to look at all the aspects, all the tips and tricks, and do it in the right way, and there's no look back. Thank you.
Thank you, sir. And again, thanks, Professor Rutledge, Professor Kular, for your time. And thanks all of you viewers. And at the end, I will request so you can ask questions. And also, I will share these questions with both of these legends I can ask. So hopefully, we will continue our activities, and on weekly basis, we will continue such interviews. And first, we have started this MGB OA-GB series. Hopefully next week also we will be with another legend, and we will ask other questions, same question, and you will have this opportunity to ask. And with the passage of time, we will see after 8 or 10 interviews, yes, then you can, and maybe again we will take Professor Rutledge, Professor Kular. So because this MGB is not like just now you can see within 1.5 hours, still we feel hungry, so we have lot of questions. So we will continue our this debate, our this interviews. And again, Sir Kular, thanks. Sir Rutledge, thanks. Have a nice time, and good night. Thank you, sir. Thanks a lot.
Good night. Thank you very much. Good work.
Thank you, sir. Thanks a lot, sir. Thank you. Have a nice time, sir. Sir, see you again.
Sure.
Thank you, sir. Thanks a lot.